So now we're going to move on to a panel discussion. I'd like to invite Dr. Caitlin White from ACWA to come up with the panel members Ray de Russet from GP Down South, Maggie Peel from Grams, and Dr. Daniel Hunt from WRN Health Service. This panel discussion will highlight the importance of primary health care in promoting and improving ear health outcomes, and this session will focus on current ear health practices in primary care across WA, identifying what works well, where there are opportunities for improvement and future priority areas. Please join me in welcoming Dr. Caitlin, Ray de Russet, Maggie, and Dr. Daniel.
Great. Hi everybody, I'm Caitlin. I'm the Public Health Medical Officer at the Aboriginal Health Council of WA, so I'm a GP and public health physician by background. Previously worked up in the Kimberley as a GP and in public health. I'll just start by acknowledging we're on Whadjuk Noongar Budja and pay my respects to elders past and present and extend that respect to our Aboriginal and Torres Strait Islander colleagues in the room with us today. I might hand over to these guys to introduce themselves and then we'll ask some questions. Ray, would you like to start?
Sure. Hello. Is that on? Yeah. Hi, my name's Ray. I'm a registered nurse and background in child health, and I work for GP Down South, down in Manjimup in the Warren Blackwood region on Bibbulmun Budja. Previously, I worked in maternal child health within the e-health space in the Archo sector.
Great.
I'm Maggie. I work at Grams in Geraldton, and we have the outreach services in Mount Magnet and Carnarvon in the Gascoyne that we run as well. I'm one of the clinical managers, and I've been at Grams for about 5 years now.
Yes, hello, my name's Daniel. I'm I'm Jara Nichibandi Man, and I'm the Deputy Medical Director of WRN Health Services on Whadjuk Noongar land.
Great. So as I'm sure we're all really aware, primary healthcare, so general practice or other primary healthcare services like our Aboriginal community controlled health services that provide a comprehensive model of care are really important in ear health and managing chronic otitis and media and other ear disorders. So I'll start by asking you guys, why is ear health in primary care so important? Dan, do you want to start?
Yeah, I think it is important because it's sort of discussing this morning with a few others. It's one, obviously quite a common issue, but also relatively simple to treat and manage with the appropriate investment, not just from our sector, because we're probably doing quite well with what we get for assistance, and it just sets up the child on a trajectory, which is a lifelong trajectory, and and it's simple interventions and simple measures. The antibiotics, that's relatively cheap and simple product to get. It's the lifestyle and home hardware and interventions that's relatively simple, and if the child needs grommets, that's the bread and butter and the no brains included procedures for the ENT. So it's all relatively simple interventions. It's just trying to find a model that works well, but ultimately what we're looking at is what trajectory it sets this young person on for their lifelong. We've had issues with during COVID in Banksia of children being locked up and being named as sort of the bad child, but what it was a child with significant hearing loss from chronic ear infections, and everyone's wearing masks because they've learnt to lip read, and they ultimately ended up being locked up as a child that was incarcerated because ultimately of some form of hearing difficulty. So it's this is relatively simple fixes. So and I think it's just the way we set up our kids on their lifelong trajectory. That's why ear health is so important.
Thanks, Dan.
Absolutely. I think by having it in primary health care, you've got the opportunity to be opportunistic, and it's that holistic care. So it's not sometimes just about the ear, but everything is around it. It's the barriers on why, say, nana or pop or mum can't bring the child into the service or the services that are provided because there's barriers there, and then how can then we as the health service give that holistic care. And then from the referrals into the ENT, maybe it's then a referral into our social emotional wellbeing team to then do support letters for priority housing because it is overcrowding, or there's homelessness that is there as well. So you can kind of get that holistic flow going, and then it can be back into the child health nurses or team up to immunisations, then back through the schools that we've got great connections with as well to say, right, we've got a few concerns about the child, we're needing speech, we need OT, so then we can be that main to do that. But without Aboriginal health practitioners and liaison officers, that is extremely difficult to do. So that's where we need funding, and it needs to be funding that's going to be there to stay because it's not going away. And you don't want to put in a program and put all the hard work, because it does take up to 6 to 8 months to actually get that program going, and then the next thing that funding can be pulled. So I think funding is definitely a big thing, and really empowering families with really great health promotion as well, which is another gap, I feel. And obviously I spoke yesterday about the ENT, and I know that comes with a lot of extra components to be able to get an ENT service to provide. But hopefully, we once had it back in Geraldton, hopefully we can do it again. We used to bus the kids in and the family members, put them up overnight from Magnet, Carnarvon. So it would be really great to get that collaboration back again, but that takes a team and external agencies to be able to do it as well.
I think I agree with all of those comments as well. And I think ear issues, other than congenital and significant trauma, they're a preventable condition and can lead to those lifelong problems. It all taps it back into the social determinants of health in terms of if you've got hearing loss at a young age, your development, and therefore your learning abilities, which then lead into your employment opportunities, and which then affects where you live, and overcrowding, and your access to healthcare as well. Traditionally, primary care was very accessible. It's not as accessible anymore in terms of the affordability. There's not a great deal of general bulk billing services in a lot of areas. So you do have to, I think, look at it from a preventable perspective in terms of what are the underlying causes initially, rather than just wait to treat within the primary sector. But the primary sector is the first port of call for those families, so that's why it is the most important to fund those areas effectively, and to utilise the scope of practice of those people that actually work in those areas as well. I think there's a huge underusage of those people who work in a typical nursing role, whether that's an Aboriginal health practitioner, enrolled nurse or registered nurse. Their scope of practice isn't as well utilised, I think, within the primary sector as it is, say, within the tertiary hospital sectors.
Great, thank you all. I think we've had some really good points there, really reflecting the breadth of the scope of primary care. So about prevention, that's really where we can tackle prevention and provide health promotion. We can provide opportunistic care. We can impact kids' lives into the future through that, and primary care is accessible. I really liked, Maggie, what you said about Aboriginal health practitioners and Aboriginal liaison officers. I noted in the otitis media guidelines that we just heard about, it states that Aboriginal staff working with Aboriginal families are likely to have the greatest impact on reducing severe otitis media and assisting children with hearing loss. And I wondered if you guys had a comment about how Aboriginal staff within your services work in your ear health programs.
Well, unfortunately, we are under-resourced with Aboriginal health practitioners, and then that comes to a whole nother big issue around training and support, because people have to come off country to come down to do blocks, and that is a big challenge. I know the Kimberley have got an RTO up there, which is great, but I think and getting into the schools early to help to promote that as a real career pathway, and there's not only just Aboriginal health practitioners to be in an AMS, there's everything around it. But it's that empowerment, and I think the training opportunities.
Thanks, Maggie.
Yep. I also think the funding for the number of them, it puts a lot of responsibility on a few people, which and they're not just covering ear health; they're covering so many other chronic health conditions across a lifespan, and within themselves, their family, as well as all the clients that they see. So it really needs more funding to have more of them, and it's that opportunity for training, but opportunity for employment, because you can do the training, but if there's no jobs available, that's also a barrier then, isn't it?
Sorry, and I'll just add, and I think there's competition as well for Aboriginal health practitioners because they're so sought after. That's also an issue. Yeah.
And we're also welcome to take them at Derbyl. Yeah, so I think having an Indigenous workforce is obviously integral. We've got through pinching for little bits of funding here and there, we've been able to put together a funding for our ENT coordinator, Stephanie Blurton out the back there. If you want to turn around and say hello. There she is. So she's been leading that ENT coordination this year, and that kind of stuff is vital because Stephanie is looking after one system, one specialty, and that requires a lot of time and effort. If you were at the presentation on Wednesday, I think for a few hundred patients, it's required 1,600 administrative interventions by Stephanie to sort of provide that wraparound care. But so that kind of targeted Indigenous staff working in this area is vital to this. But I think kind of case coordinators for all the conditions, all our issues are RHD, ENT issues. I think is sort of vital in our area.
Thank you. That leads me on to my next question. What elements are vital in a ear health program in your service?
Training, I think, training and regular training as well, refresher training, which the lovely Lorraine does annually. So you just need to keep continually updating that training and equipment as well, because you need that equipment to be able to go out and screen people, test people, and access to treatment as well, and referral pathways.
Yeah, I think that's exactly it. Clear and appropriate referral pathways. I've seen from one of the presentations the absolute mess that it is referring a patient from regions to a tertiary service in here. It's diabolical, and even just clearing up the referral pathways. I'm a general practitioner and my bread and butter is doing referrals, and even I find it hard to sort of glean how appropriate it is or how to do certain referrals. So I think it's clearing up the referral pathways and simplifying it. So we've had the luxury of Mr. Peter Friedland assisting us with doing some surgeries in Joondalup, and but only through his philanthropic work really, where he's managed to free up space on his theatre lists in Joondalup, that we're getting ready access to our children and adults accessing theatre. Breaking it down from about a couple years wait really to a couple months, but that's only through philanthropic work really, not by virtue of any genuine assistance from the government. So I think it's clear and easy pathways, and probably just having the staff on the ground really assisting. So it's wonderful seeing the dedicated work that does come out of the ARCHO sector, but it really shouldn't be us bolstering up and looking after the patients. It needs to be sitting on the shoulders of our state and federal colleagues.
Maybe data. I know we all talk about it, but I think in some of the regions there may be 3 service providers doing audiology, and they'll be the AMS children, but there's no real communication back into exactly what that child or that family needs. It might have, prescribed antibiotics for the child, but then it's, the referral sent off, but that's where it stopped. So that would be really great. And then as a service provider, we need to look at our own data to go, okay, what are we missing? What are we doing wrong? What do we need to improve? But if we don't have the right data, then we're at a loss, and there's no room for improvement.
Any other comments? No? I guess on that, for your own service, what do you think is working well at the moment in your e-health programs?
Well, as I've highlighted before, is the case coordination and having someone targeted doing that role. That's worked very well. We've streamlined our internal referral processes to our ear, nose and throat services. So we have Francis and Peter assisting our services, and also, you know, I can't remember off the top of my head, 2 different audiology services that come and look after our patients as well. But it's probably just having that one coordinator, because until we had a coordinator, we had referrals left, right and centre, and nothing sort of streamlining those, and having someone dedicated to our specialist referrals probably does help. So having one person who's responsible.
And having on-site services come into the AMS as well, and then being able to link it back into the child maternal unit for your speech, your OT, Hearing Australia. We have the lovely Anna that's come on board for Geraldton and Carnarvon as well. And I think if you have the regular people, that the children and the families build up that rapport as well, then you get better health outcomes.
I think in the Warren Blackwood it's quite a new space for ear health, being that it's only an hour and a half drive. However, there's no decent public transport other than the statewide service, so it's very difficult for children. If they're identified with an issue, they have to go to Bunbury, and that's a 3-hour round trip with quite a distance in between if you are relying on that Trans WA. At the moment, we've got staff that have just completed some training, and being a small rural area as well, you've really got to build that interagency approach in terms of linking with the WACS child and school nurses, communicating with the GPs what is appropriate. And I know WACS is looking at developing some play audiology service down there, so we can do pre-screening in the region. So the people that then have to go up to Bunbury are those that have been identified already, not just drive up there and then find out there's no issue. So it's having that interagency approach, a multidisciplinary team approach, to do some pre-screening locally to reduce that amount of travel and identify those that really need that full audiology screen, and to then go through into ENT or surgery if needed, or what else is appropriate, and just to reduce that unnecessary maybe, or to clog up wait lists. The Bunbury services the whole southwest, so they do have an extensive wait list for that whole rural area. And I think because it is an area that's only an hour and a half from Bunbury, and it's not too far from Perth, it's not really seen as having the travel distance as being an obstacle in the same way as the Goldfields or up north. But it actually does, because it's a lot of people don't have their own transport. It is in the lowest 30% socioeconomic status of the state, and I think the 1 in 5 children have been identified with a developmental delay across one or more domain, and that's all children, not just Indigenous children. So that's quite concerning. So, and a lot of that is just purely speech, and WACS are very overloaded. Their workload's quite huge. They have a small FTE down there, so it's all about collaborating and how we can make the best use of staffing resources. Yep.
I think another thing was also, and the tertiary services seem to be terrified of these options embedding specialists into primary healthcare services. The ARCHO sector have been doing this quite successfully for about 50 years, and our service, we've got 14 or 15 visiting specialists, and that provides a more culturally appropriate and safe environment for our patients to attend, and our attendance rates are higher than what's reported in the public service. So I think it's sort of focusing on that, and I think this kind of model of care has only recently got traction, unfortunately, because the Norwegians have been doing it for about a decade. But yeah, it's disappointing that it took a Scandinavian country to do it to get precedence when the Archos have been doing it for about 50 years. But you know, one example I use is our PEDS, developmental PEDS service. We've got a roughly 97-98% attendance rate, whereas our PEDS developmental attendance rate is, I think, 30 or 40%, something like that. So in the public service, so it just really goes to show that a culturally safe and culturally appropriate program embedded within primary healthcare works.
Thanks, Dan. We've heard about some of the challenges, particularly around funding for appropriate staffing for things like case coordination and also surgical wait lists. But what are the other challenges for your services at the moment for ear health, your ear health program, and also you're thinking about screening of children when they come into your service?
As I mentioned, our staff are just newly learning, so they've just finished their training. So I guess it's the skills and experience to build on. But being that it is quite a broad area, as I mentioned with the distances, it's also ensuring that staff within GP practices generally, which we don't have a dedicated AMS down there that's there 5 days a week. SWAMS visits with a GP 1 day a week. So, and within our service, we have Aboriginal health practitioners, well, one in the Warren Blackwood and one in Collie. So they do link in with the other GP practices. So it's ensuring that those GP practices are all so up to date with that information and the guidelines, and the nursing staff there as well.
Yeah, I think it probably does come down to a lot to education and maintaining that education for our staff, but also our patients have, you know, I'd love them just to have one issue at a time, but our patients have lots of issues and overriding issues, and you know, our children are seen when they get their earaches, and you know, after a fortnight when the antibiotics have done their job, that may not be the overriding pressing issue for that family at the time. And so, you know, we've got a lot of other competing issues, and sort of breaking down those barriers, you know, having, again, the case coordinator, or having available transport, or having a social worker on site, or those other facets, because I'd love our children to only have ear health issues, but there are so many issues that having, once again, access to primary health care and the ARCHO sector, where our, you know, mum can come in with their child and be seen by get their ear sorted and have a chat to our child health nurse and see the social worker if needed, and can pop along to the sexual health nurse or whatever is needed. So, you know, trying to be a bit of a one-stop shop for those patients on that day, because of, you know, the overriding issues that our patients have and other competing demands.
Absolutely, I'd agree with that as well, because the carers of the children may have 3 generations of chronic disease in the family, and you know, Nana might need dialysis but may be waiting for a bed, so was in Perth, relocated. So I think it's all those extra factors that come onto why the children aren't getting early access or prevention into the ear health. So that then does come down to the opportunistic, and I know Derbyl Yarragon do it really well through their child maternal unit. It is a one-stop shop. So then you've got the GP that's linked to the PED, that's linked to the child health nurse, paediatric coordinator, ENT coordinator, but that all is money and it's all resources. And that's where I think a lot of the AMSs and the hospitals too we're lacking in the actual hands on the ground to be able to really contribute. And also, you know, we put a lot of pressure on the Aboriginal staff as well. There's a lot of cultural loading that goes on top as well, because it's not just about the AMS, it's about the external factors that happen in and around working within an AMS and with the Aboriginal staff too. So I think that absolutely needs to be factored into it too.
Thank you guys for sharing those challenges. I'm going to ask a really hard question now. You might want to pass. Something that I've struggled to think about and figure out how it works in a clinic, and acknowledging the competing demands of patients and of clinics and what you're dealing with. Amanda Leach spoke about, you know, the importance of assessing tympanic membrane mobility, either with pneumatic otoscopy or tympanometry. How do we move forward and best integrate tympanometry as a routine investigation or test within our services? Is it possible?
It's a big ask, and it's a big ask. So I know child health nurses are, but they also have to give about 1,000 vaccines in that one setting as well. So that becomes an absolute challenge. But it comes back then down to training and making your business everyone's business to be able to do it. But it's, yeah, I think it is a tough ask, absolutely. But education and not relying on the one person, and that opportunistic, if a child's coming in, like we said before, having a wound dressing done, great, let's have a look in those ears while we're doing it. And I think we really need to incorporate that into our service delivery.
Yeah, I totally agree. I think the trying to integrate it in so, you know, it appears as a clinical item on our 715 checklist on Communicare, and sort of trying to integrate it into our standard care for the pop-up item that occurs for the pre-consultation screening. There is also a fear if we don't do these things regularly, we de-skill and worry about providing harm. I think from my chats to my staff, I think they're worried they're going to do some damage to the tympanic membrane just because they're just not having that regular education, but we're teeing up some more for our staff. And I think it's integrating it into everyday care. So, for example, I look after our syphilis point of care program, and I've just sort of tried to make it as a matter of fact that it just needs to be done when a patient who fits the criteria comes in. And I did get some complaints that we've got 100 things to do, and I said, well, adding one thing to 100 isn't too bad, because if you only had one thing to do, adding one more thing would double your workload. Adding 1 to 100 is not too bad. So it would just have to integrate it as normal workflow, and this should be the expectation that as a kid comes in, we get TIMPs, and we're just trying to integrate that into our workflow. And we've got a very motivated maternal child health nurse at the moment who's coming in and trying to fix everything at the moment. So I think that kind of motivated, and that's what we do have. Archosectus suffers greatly, not suffers, probably the wrong word, but has a uniquely motivated staff. So who will get things done. So probably just travelling along those lines and integrating it into what is normal care.
Yeah, I agree. It's a very quick check, the tympanometry. I think it would be encouraged a lot if it had some really good Medicare billing behind it. It's nurses, Aboriginal health practitioners, they do a lot of tasks within practices, and there's not a lot of Medicare billing that reflects the amount of work that they do. They're essential in hospitals, and it's very well recognised how essential their care is in hospitals, but once you step out of that, they're not seen as being key to primary health care. And I think especially in small rural areas where I work, there's a lot of small general practices that rely on Medicare billing and private fees. So if you actually had their nursing staff that they could get that Medicare billing for, that would probably integrate them more within their practice, because they're an expense that they can't often afford on top of all the rest of their expenses. And I think the government needs to probably recognise that skill set a bit more highly within primary practice and fund it a bit more broadly across areas. Yep.
Thanks, Ray.
That would encourage it a lot.
Yep, that would encourage people. That would be good. I want to talk a bit about what happens in primary care after a child's been diagnosed with otitis media, whichever type, and say has been referred to, say it's CSOM, they've been referred to ENT. What happens after that referral's gone off but the child's undergoing treatment? What happens then? And I guess what are the solutions within your service for managing recalls and looking, like you said, Maggie, at data and looking at what's happened to this child before so that we get the right treatment and the right diagnosis at the right time.
Questions? From my previous experience when I was facilitating the eHealth program, once they were referred, once they were identified and had otitis media and were receiving treatment through a GP review, and if they got referred to the ENT, you'd monitor them. The patient software had recall systems in there that you could monitor them effectively. But again, it's also down to your staffing. You need staffing to be able to monitor all those various recalls across a client's life and their family. So, yeah, once you've got the recall system, you've got the treatment, and there's the follow-up from that to review them, and then you're just waiting for ENT review, I guess, and that can be a length of time.
I think it's one of the things. So when the otitis media guidelines came out in 2020, we sort of scrapped the kind of garbage that was sitting in Communicare and created our own clinical items and recalls to those standards. So that did actually improve our management and treatment rate for our children. So, you know, one is matching things to best practice and and sort of overhauling those clinical items in Communicare to match treatment. And so, you know, as soon as a certain diagnosis is made, a automated recall is placed into the file, and those patients are recalled. You know, we also have dedicated recall officers, one who does recalls for all sites, and then we have, you know, our nurses who are and AHPs who are assigned to recall tasks. And once again, having the new ENT coordinator does assist with this, particularly once the patients had the referral. But the thing that really helps us greatly is that because we've had the essentially philanthropic work from Clory's team and Friedland's, we do have a short wait to theatre time, so we're not too worried about that, you know, 300 to 600 day wait that our patients would have. At the moment, it's, you know, 2 months. So, but that's only philanthropic, and that will not last forever. And, you know, these ENT surgeons are getting old and may not want to keep doing this forever. So, yeah. So at the moment, we're not too concerned with that wait time, but that will blow out again once these old boys aren't able to do this surgery anymore. Yeah.
Got anything, Maggie?
No, I just want Dan's order of his of the guidelines of Communicare. Thanks, Dan.
Yeah, I was going to say, Dan, can you share those items? Great. So last question from me, and then if we've got time, maybe from you guys. What can the sector and the strategy do to support primary care better?
Money.
Yeah, it sounds like, I think from what you guys were just saying, you know, the follow-up and the recalls and the management of cases, you need more workforce than you can get through MBS billing, through, you know, private general practice, recall officers, Aboriginal health practitioners, care coordinators. Yeah, that's not covered by MBS billing.
And it's also, there's a huge shortage of GPs coming through, especially into rural areas. So it's also by funding all those people to do all of that follow-up work and nursing staff, Aboriginal health, you're supporting GPs. So you're going to have GPs moving into general practice because they all are aware of how stressful it is and how much limited time you have with the client. So that puts so much pressure on a GP, and in small rural areas, sometimes you're the only GP in that region, and then that's a massive responsibility. So a lot of general practices or GPs don't want to go into that sector. So the workload's increasing, the funding is not, and the staffing is not either. So it's the well-being of the workforce needs to be supported in order to do the work.
Yeah, I think it is. Yeah, I mean, every time we come to one of these kind of events, whether it's eyes, ears, or otherwise, is the same rhetoric that it is that sustainable model of care and funding that we need, and it's not, and that's for all our staff in our sector, because it's not just the general practitioners; it's everybody else around them, to administrative staff, and it's a struggle across the board. I think in Metro, I think people assume we're fine, but we do struggle with AHPs and nurses and retention. So I think thankfully it's not just us, it's everyone. Yeah. So I'm pleased about that. But yeah, it is that sustainable model, and it's disappointing that our sector is constantly relying on philanthropic work and small non-sustainable grants and pilot programs. So yeah, that's probably anything that's consistent to sustainable.
Are there any questions from the floor for these guys? Yeah. Go Joe first.
Thanks, guys. That was very interesting. I work within the WA Country Health System, and part of our programs are screening. And so some of the frustrations from our perspective is that our child health and school health nurses will be out screening and identifying the issues, and then needing to refer through to your services, which when we screen may not line up with your recalls that you've got for these patients as well. So I don't know, we're trying to work out how we get them seen, because we've seen them as well, but you guys are obviously seeing them separately as part of their bigger picture stuff. So how we can tie all that up a little bit neater, cross-sectorially, I guess, is a challenge. And our policies will say, for example, 2 type C tympanograms, and we need to refer to their GP. So our staff will follow policy, but they'll get to see the doctor at the AMS, and they'll go, "What's going on here? Why are you here? Sorry, I can't quite understand." So I don't know how we can take this at a higher level, these sorts of things, just to make sure that the patient's the centre of the conversation, I guess.
Do you guys have any comments on that?
I think it probably comes down to having that appropriate two-way communication. If you're a WACS or otherwise service in a local area, it's probably having an appropriate MOU with your ARCHO sector, so we know why and how and what the information that's coming through are for. We do have patients rock up who've been told to turn up to us, but they don't know why. We don't have any information why. So it's really just a fishing exercise and guessing sometimes. So I think it is for true appropriate governance of these programs to have those meetings and interaction with your local ARCHO. So there is that MOU, and that really just opens up the flow of communication. So I think establishing that's why these days I don't move unless I've got some kind of MOU with a service, because that provides us the rights and responsibilities of each party to what we're doing and what information can be provided. So I think something like that's how we sort of operate with our governance at Derval. So I think something like that would be appropriate.
Do you agree, Maggie?
Yeah, absolutely. And then if you've got that ear health coordinator, that one contact as well, or within a team, to be able to then do a external referral into that team would be great as well, whether that's via email or have that MOU but still have that contact to go, hey, we need to get this kid into the GP, and depending on what data or what information you can give us from your side, I think will make the difference.
I think also it might be good from a national level. We have an Australian Register of Immunisations, and all the children's dental records are kept all together. that maybe there needs to be a one for ear health, so it doesn't matter where the child goes, they transfer schools, you've got access to their ear health records, and that can be easily retrievable. I don't know if those screening results can go onto their My Health record or something like that, which is easily identifiable as well. That would be probably really helpful in terms of information sharing around these, something that's impacts significantly.
Thank you. Yeah.
Hi, I'm Anna. I'm an audiologist. So I just picked up on, I think it was a comment by Ray, but I think it was also a common thread with Maggie and Daniel's comments as well. In terms of tympanometry and access to Medicare rebates, they are now, as of last year, available to audiologists doing tympanometry. So just thought I'd bring that up, in that there may be an opportunity. So there needs to be a GP referral for it, but there may be an opportunity to sort of set up a process where, you know, there's a whole bunch of referrals done and an audiologist can come in and do the tympanometry and give the access to the Medicare items that way. So just a point for consideration.
That might be interesting if it's Rural Health West funding though, so
Yeah.
Fiona or someone may be able to answer whether it's because it's some of the audiologists out through outreach
Yeah.
are through funding, so it'll be interesting to see what that looks like.
Yeah.
Morning, Philomena again. One of the things I was listening to is, as an Aboriginal health practitioner, there's more things that I can claim, let me stand up so you can see me, that I can claim through our clinic, and it'd be really good if there was something there to be able to claim for ear health, because I know the clinics push for us to do the things that they can claim money for, because that provides funding for jobs, etc., etc. So it would be really good if there was something within the Medicare levy that we can also put a number down for ear health.
It's a great idea, Philomena. And so I guess for those who might not know, AHPs can claim for immunisation, for wound care management, and for a range of follow-up items. Also for assessments for chronic disease management through chronic disease management plans. Is there anything else I'm missing? What was that one? Yep, so the care plan follow-ups. Yep. Yep. So all those pathology items as well on behalf of the... So there's a range of items that the GP claims. It's claimed by the GP, but the service does it on the GP's behalf, but there's also items that the AHP claims directly under their own provider number. So that's a really, really good point and might encourage specific ear health TIMPs and those sorts of things.
There used to be just a TIMP number, and then it changed to now you've got to do a TIMP and a reflex to claim it under the GP.
For the audiologist to claim?
No. If anybody can do it on behalf of the GP. But I thought it was an 11327, and then we tried to find that yesterday, and it seems it's now an 11324. And there's, I don't understand how Medicare changes things, but that's... sorry. And then there's a hearing screening number that can be claimed under the GP as well, and I believe that's an 11306. Yeah. So the 11 so there's some that can only be claimed under a specialist. Yeah. But there's a couple of the 11 numbers that can go under the GP as well. That they haven't been rejected so far anyway.
The D'Urbals, we've got a Medicare revenue officer, and she sent me a long email about TIMPs and numbers, so I haven't had a chance to read it because her emails are way too long. But if it's relevant, I'll
Can you
forward
forward
to
it to me,
Caitlin
please?
to
Yeah.
send around.
I'm
Yeah.
not aware of those numbers, but yeah, if you could send them to me, that'd be good.
If it's relevant, I get a lot of non-relevant emails from her as well.
Maybe, Laura, is that going to be our last question? I can't see you in the room. I feel like, yes.
One
Oh,
more-
two questions.
You want to
Yes.
ask a question?
Let's do those. No.
Oh, I was just thinking on behalf of our Metro community health nurses. I know one of the struggles they have is that they refer to their local GP or the families to the local GPs, but a lot of the GPs actually don't have the training or the understanding or don't have TIMPs in their practice. And I know I often say in the training, say to them it's suggestive of whatever, it's consistent with, we can't diagnose as nurses or whatever, but saying that, and because a lot of GPs might look in the ear, and I can understand with the cost of, when you've got ear tips that are, 10 for $20, $2 each, effectively, it's expensive for them to do it opportunistically. And I was listening to Ray, Ray saying, if the practice nurses or the nurses in the practice could do it, if it's not Medicare, then why would the GP? It's expensive. So there's a few issues in terms of the funding for them and also the education. I don't know I'm hoping more GPs are getting. I had a colleague who actually went in for something else and ended up spending the whole appointment because the GP was really keen to hear about what does TIMP actually tell me and what can I understand. And once he got that understanding, I think there's that drive. So I don't know, in the metro area there's so many GPs out there, but they obviously it's up to them whether they want to. So I'm not sure if there's out there education programs that are, I'm sure there are. Yeah. And not having that understanding of, if you're not hearing this, it has huge implications for their whole development and everything, the whole trajectory.
Peter.
Yeah, so certainly that's something the strategy can try and help with in terms of through WAFA, I guess. So they are a partner, so they potentially could spread it more broadly outside the ARCHO sector. My question was, can we not use telehealth as a sort of a video conference, with a multidisciplinary approach where you have a audiologist somewhere who's connecting with the GP, with the patient? My understanding is you can claim for that. Is that right? You or not?
Oh, absolutely. But I think it's also comes down to that sort of basic infrastructure.
Yeah. No. But if we could set that up, that a GP anywhere in the state could dial into a video call with a. Yeah. Is that something like we do for emergency setup?
Well, I think all GPs in the ARCHO sector would absolutely welcome that. I know there's that hive that was set up during COVID, and
I don't know what happened to that.
But that sounded quite promising. But I think it would probably need Aqua to help out with a lot of infrastructure before we could do all that. Yeah.
Oh.
There's options, now for, there was a tele-ENT pilot with the ENT specialist, video otoscopy. There are Medicare items that allow the nurse or AHP to bill on behalf of, or to the GP bill on their behalf, but to provide telehealth support on the patient end when they're dialing into specialists. So there's a range of things that are available and that quite a lot of our services do. But yeah, I guess the audiology infrastructure and how that might work. Are you talking about to do an audiology?
Yeah, I'm just thinking about the ability to make it feasible for, small general practices anywhere in the state, if that they could get expert advice if they have the equipment, to. no. But I'm just saying if that
to
was
use the equipment, and so especially if it's video otoscopy, and if you're not familiar with, we did a video uplink with the Wheat Belt through one of the ENT clinics when I was at SWAMS, and the ENT obviously sees all those images all the time, so even though it was blurry, he could tell what was needed, but it still needed that person on the other end to be quite familiar with the equipment, so that means that requires training for that person and also regular usage of that as well. But that was really good. It meant that children from Narrogin didn't have to drive all the way over to Bunbury, and they were able to, be like, yeah, that's fine, or not, to review them. So it's definitely helpful, but I think it's one solution.
Right, I think we'll have to wrap up there, but thank you to our panel. Big clap for our panel.